We are now in week 6. We will begin our hematological assessment. We'll be looking at what kind of signs and symptoms our person that has these disorders, what they look like, and how these patients are going to be feeling. So let's begin. HemeVOweek6 is the development of our white blood cells. These as you can see on the slide, are how our stem cells divide and then become a variety of different white blood cells. These are also going to be where we get our red blood cells and our platelet producing cells, all the good stuff that's in the blood. And we're going to go into this a little more. If you have questions, you can certainly review the pathology, but I don't think it's going to be terribly necessary. But you can definitely see there's all sorts of different types of blood cells. It's not just one type. So this slide shows a shift to the left. It indicates that there are more immature cells present in the blood than normal. It usually indicates more immature neutrophils known as bands. Why is this significant? So if you have more immature cells, basically we're throwing out our babies to go fight a war. Our war is the infection the body is building against, our viruses and bacteria and protozoa. And when we have a left shift, it means we're kicking out a lot of immature cells that are just really not quite ready to do the battle. So again, you send babies out to the battlefield, they're not working so well. Technically there's bodies on the field, but they're not bodies that are really able to do anything. So you find this left shift occurring with acute infection, inflammation, physical stress. Mature cells have worked and died, and we have these immature cells that are left and very ineffective in fighting. So what does our blood do? All of our tissues rely on oxygen that is transported in the blood. However, there's some other things. We have, of course, oxygen delivery. We have the clotting cascade. So if we get injured, we get scratches, we send our blood out there to start clotting and protect the skin until the skin can heal. It also helps with inflammation around the body because that's part of our, healing process, and immunity. So this is where we get, white blood cells going off and, battling infections and protozoa and all of that, so that our body is healthy. So the blood does a lot of things, not just oxygen. So oxygen, clotting, and inflammation are really big parts. So what this means that if there's a problem with your blood, we're going to have problems with oxygen delivery. We're going to have a problem with clotting. We're going to have a problem with immunity and inflammation. So anything that interrupts what our blood is doing, either we have too much of something or not enough of something, or we're being overrun by infection, all of this is going to be affected. So when we're looking at our patient who we suspect has issues with our hematological functioning, we have to look at very important things. We want to ask, have you had any recent change in your energy level? Have you had any difficulties maintaining usual daily activities, including recreational activities and sports? Have you been experiencing pain, burning, or tingling sensations? Any changes in skin color or temperature? Any swelling or edema? Have you experienced any bleeding, bruising, dizziness, fatigue, changes in your lymph nodes? So all of this can indicate that there's a problem. We all get tired. Everyone gets tired. You've had a long day. There's a lot of stress. However, if you're doing very little and you're still very tired, that could indicate a heme dysfunction. You know, if we're getting numbness and tingling specifically around the mouth, that can mean you have a vitamin deficiency that affects your blood. Are you super easy to bruise? When you get a cut, is it just bleeding and bleeding and bleeding? And you're like, well, that's kind of weird. You know, all of these things are unusual signs that there could be a problem with our heme. Dietary patterns can alter cell quality and affect blood clotting. We want to ask the patient about their usual diet, including protein, vitamin, and mineral intake. Diets high in vitamin K, such as raw leafy green vegetables, may increase the rate of blood coagulation. Again, that's why when we have people on things like warfarin, we discourage diets that are very high in vitamin K because it's going to counteract that medication. We want to look at diets high in fat, carbohydrates, and low in protein, iron, and vitamins because this can decrease the function of all blood cells and potentially lead to different types of anemia. We want to ask about the use of tobacco, alcohol, and other recreational drugs. Chronic alcohol use is associated with nutritional deficiencies and liver impairment, both of which can decrease the ability of the blood to clot. Obtain the patient's medical history, being sure to ask about any chronic diseases. Any liver issues and even cholelithiasis, which is the gallstones, can affect clotting and bleeding. So we also want to ask about pregnancy because the incidence of gestational thrombocytopenia is observed in about 5 to 11% of all pregnancies. Inquire about current medications, including anticoagulants, aspirin, other salicylates, herbs, nutritional supplements, and nutraceuticals. So some dietary supplements may interact with prescribed medication therapy. For example, golden seal and green tea may reduce the effect of certain anticoagulants, thus increasing the risk of thromboembolism. Also ask the patient about antibiotic use because prolonged antibiotic use can lead to coagulopathies, bone marrow depression, and other undesired effects. For example, neutropenia may occur during therapy with penicillins, cephalosporins, or vancomycin. So we want to do a physical assessment. This systemic head to toe is very important. We want to assess the whole body because blood disorders may cause oxygen delivery to be less than what is needed for normal oxygenation and tissue perfusion in all systems. Inspect the color of the skin and mucous membranes, including make sure to observe for pallor or cyanosis or fissures at the corner of the mouths, which indicate nutritional deficiencies and or chronic anemia. Palpate for skin temperature, capillary refill, and edema of the extremities. Inspect oral mucosal membranes and the skin of the trunk and extremities for erythema, red streaks, petechiae, bruising, and purpura. When hematological disorders reduce oxygen delivery, the lungs work harder to increase oxygen delivery. 4 measures of respiration, rate, rhythm, depth, and sound, reflect the body's metabolic state. It also includes, how the diaphragm and the chest muscles are conditioned and airway patency. We want to know a patient's baseline respiratory rate. That way we can detect any changes in the patient's condition. Respiratory rates of less than 12 or more than 20 are usually considered abnormal. Report the sudden onset of rates promptly. Anemias can cause fatigue and shortness of breath at rest or on exertion. This can make it difficult for patients to complete ADLs. How can we maintain our patients' hygiene when it isn't safe for them to exert themselves by being up to shower? So we have to kind of look at, are patients safe? Our nursing focus is always going to be safety. So if somebody has a dysfunction in their blood and they're not carrying enough oxygen, either through vitamin deficiency, blood loss, whatever it may be, they may be so weak that they cannot safely bathe themselves or feed themselves, and that's a very important thing to look at. When blood problems reduce oxygen delivery, the heart works harder to facilitate adequate tissue perfusion. So we're going to listen to the heart and we're going to detect and see if there's any murmurs, gallops, or irregular rhythms. Systolic BP tends to be lower than normal in patients with anemia. Abdominal or bone pain may occur in patients with hyper or hypoproliferative disorders. For example, sickle cell anemia or leukemia or infection. Assess the range of joint motion and observe for swelling, joint pain, or motion limitation. Advise the patient to empty his or her bladder before the examination to facilitate an abdominal assessment. There should be no visible masses. If the abdomen is distended, inquire about changes in bowel patterns and urination. Palpate gently, as an enlarged spleen may be tender and may rupture easily. An enlarged spleen may indicate a hematological problem, and it can also occur with liver problems. The most common test used for routine screening of hematological function is your CBC, or complete blood count. It is exactly that. It shows you the full profile of the patient's blood. So these laboratory tests, their normal values and nursing implications, are done so we can evaluate hematological and lymphatic functions. The HGB/HCT, which is our hemoglobin in hematocrit, this is what we watch for in our blood levels. A low hematocrit suggests anemia, hemodilution, or massive blood loss. A high hematocrit indicates polycythemia or hemoconcentration caused by blood loss or dehydration. The hemoglobin level is a total amount of hemoglobin in the blood, and assessment of hemoglobin levels measures the severity of anemia or polycythemia and monitors the patient's response to therapy. A low hemoglobin level may indicate anemia, recent hemorrhage, fluid retention, which can cause hemodilution. A high hemoglobin level suggests hemoconcentration from polycythemia or dehydration. The CBC can measure other features of the RBCs, including the MCV, MCH, MCHC. Mean corpuscular volume expresses the average side of the erythrocytes and indicates whether they are undersized, microcytic, oversized, macrocytic, or normocytic, and is useful in classifying anemias. The platelet count determines the ability of the patient's blood to clot normally. A count lower than 50,000 units may result in spontaneous bleeding. When the count is lower than 5,000 units, fatal central nervous system bleeding or massive GI hemorrhage is possible. Whenever the platelet count is abnormal, diagnosis usually requires a CBC, bone marrow biopsy, direct Coombs test, and serum protein electrophoresis for confirmation. The purpose of the white blood cell count is to determine infection or inflammation, to detect and identify various types of leukemia, to determine the need for further tests such as the white blood cell differential or the bone marrow biopsy, and to monitor responses to antibiotic therapy, chemotherapy, or radiation therapy. An increased white blood cell count commonly indicates infection, or it may result from leukemia and tissue necrosis caused by burns, myocardial infarction, or gangrene. A decreased count signals bone marrow depression that may result from viral infections or from toxic reactions such as those following treatment with actinoplastics. These are medications that destroy cancer cells. Ingestion of mercury or other heavy metals, or exposure to benzene or arsenics. It also may indicate influenza, typhoid fever, infectious hepatitis, mononucleosis, measles, or rubella. Reticulocytes are helpful in diagnosing and monitoring anemia. Electrophoresis is the most useful laboratory method for separating and measuring normal and abnormal hemoglobin. The purpose of this test is to help diagnose thalassemias, which are a group of inherited autosomal recessive genetic disorders characterized by defective synthesis in one or more of the polypeptide chains needed for hemoglobin production. Elevated LAP levels may result from infection, stress, inflammation, pregnancy, steroid use, and leukemia. An elevated neutrophil count without an accompanying elevation in LAP level is associated with chronic leukemia. A direct Coombs test detects the presence of immunoglobulins on the surface of the RBCs that develop through the sensitization of antigens. This test is performed to diagnose hemolytic disease of the newborn, to investigate hemolytic transfusion reactions, and to aid in the differential diagnosis of hemolytic anemias. Serum iron levels are measured directly, and blood levels should be drawn in the morning to be accurate. The patient is instructed to avoid taking any iron supplements for at least 24 hours before the test is performed. Ferritin is a protein that stores iron in the body. A ferritin level is an unreliable indicator of iron stores, but low ferritin levels may indicate iron deficiency, chronic GI bleeding, or heavy menstrual bleeding. High levels may indicate alcoholic liver disease, hemochromatosis, which is that excessive iron absorption, hemolytic anemia, Hodgkin's lymphoma, or megablastic anemia. The purpose of the transferrin level test is to determine the iron transporting capacity of the blood and evaluate iron metabolism in iron deficiency anemia. Decreased transferrin levels may result from acute or chronic infection and cancer. Increased serum transferrin levels may indicate severe iron deficiency. The TIBC is used with the serum iron to calculate transferrin saturation. For thrombin time, the PT measures the time required for the fibrin clot to form. The purpose of this test is to monitor response to oral anticoagulant therapy. So our INR, which is that international normalized ratio, is performed with that PT, and it is to evaluate the effectiveness of oral anticoagulant therapy, like warfarin, Coumadin. Laboratories convert their PT values to an INR, and this test is not used really to screen for coagulopathies. Patients receiving warfarin therapy, that therapeutic INR level is to be between 2 and 3. For those receiving warfarin therapy and have mechanical prosthetic heart valves, the therapeutic level is 2.5 to 3.5. So increased INR values may be a sign of disseminated intravascular coagulation, cirrhosis, hepatitis, vitamin K deficiency, salicylate intoxication, uncontrolled oral anticoagulation, or massive blood transfusion. The DIC, it's a clotting disorder that causes that clumping in the blood, and this causes all clotting factors to be used up, leading to massive hemorrhage in other parts of the body. The PTT, this purpose of the PTT is to screen for deficiencies of the clotting factors in the intrinsic pathways and to monitor response to the thrombin inhibitor therapy, heparin, agatroban, and we also want to look at a platelet aggregation. So these studies are performed in patients who are suspected of having an abnormal platelet function. So those who have prolonged bleeding times and have a normal or near normal platelet count. Platelet aggregation is the ability of those platelets to clump. We're going to look at some diagnostic studies, specifically examination of this bone marrow. So looking at bone marrow aspiration and bone marrow biopsy. This can be used to stage and help diagnose leukemia and other hematological disorders. The patient is positioned prone or lateral and decubitus position for biopsy of the posterior iliac crest. The patient may experience feelings of pressure upon the insertion of the biopsy needle, and a brief pulling pain will be experienced on the removal of the marrow. Some patients can hear a crunching sound or feel a scraping sensation as the needle punctures the bone. This diagnostic study is also performed to determine causes of infection and to monitor for myelosuppression. So, bone marrow biopsy and aspiration involve this collection of soft tissue. It is performed under local anesthesia with a needle. The aspiration biopsy will be the removal of fluid specimen from the bone marrow. The needle biopsy will be the removal of a core of marrow cells. It's common to perform both at the same time in order to get the best possible specimens. So before the test, we want to ensure the patient has received teaching from the provider performing the procedure, has informed consent, and that all allergies are documented. We want to assess for bleeding. We want to look at medical history, coagulation lab results, platelet count, anticoagulant therapy, and other medications or supplements that may interfere with clotting. We want to explain the purpose of the test and the procedure. Explain, how they're going to feel during the test, how long it takes. It's really only 5 or 10 minutes. We want to assess for anxiety. If the patient is anxious, we need to use some relaxation techniques or possibly administer a mild sedative. We want to assist the patient to the appropriate position and maintain comfort. Encourage deep breaths and relaxation techniques during the whole procedure. After the test, we're going to apply direct pressure over the puncture site according to whatever your policy is for 5 to 10 minutes until the bleeding stops. Cover the site with a sterile dressing. This is going to be really, really important if you have a patient who has a bleeding disorder. It's definitely a priority. We want to instruct the patient to rest for several hours. Report bleeding that completely soaks the dressing or continues for more than 24 hours. Reinforce the dressing if needed, but don't remove it. Properly label and promptly transport all specimens to the laboratory. Assess for post-procedural pain and provide analgesia as ordered. And we want to teach our patient to watch for signs of infection. Really important questions to ask ourselves. If we have a low H&H, which is hemoglobin hematocrit, what do you think that patient is going to look like? What do we expect if our patient has low platelets? What does it mean if the patient has a high PTT or PT? This is something where you're going to go out into the field and you're going to see some distinct similarities in these patients. So let's look at the first one. A low hemoglobin and hematocrit. So they're not, for whatever reason, perfusing as much oxygen around the body as they should, for whatever reason, for whatever nutritional deficiency that they have. So if someone doesn't have enough oxygen, what do they look like? So if you said things like pallor, fatigue, weakness, dizziness, activity intolerance, dyspnea, low O2, hypotension, tachycardia, those things are absolutely things we can see. I've seen patients that have low hemoglobin that are extremely pale. I've seen another patient that has the same number that's not pale. Mostly they are very weak, and all of this is individualized, but there are some similarities. What about our person with low platelets? What do they have? So we know if you don't have enough platelets, you can't clot, right? So we might see bleeding, bruising, petechiae. What do we need to do for these patients? Yes, we need to implement bleeding precautions. What about for our patient that has a high PT or a high PTT? it means it takes them longer to clot. So we need to kind of find out why. Do their medications need adjustment? Is there something else going on? Again, we have some issues with bleeding, and we may need to put our patient on bleeding precautions.